Usually, when we think about how the human body works, we kind of think of it like a car.
Right, yeah. Like a biological machine.
Exactly. You
Yeah.
have the base model, the chassis, the engine, and that's just your basic biological function, doing what it's supposed to do, just sort of humming along quietly in the background.
Right.
But then you start adding aftermarket modifications, and I mean, some of those enhance the performance, but some of those modifications completely alter how the machine runs.
Oh, absolutely. Sometimes in really drastic, terrifying life or death ways.
Yeah. And today we're actually doing a deep dive into a piece of biological machinery that gets heavily modified by just, a few tiny letters. We're talking about the suffix "nea."
Which is such a fascinating family of medical terms to look at.
It really is. It comes from the ancient Greek root "nine," which simply means to breathe. I mean, it is the ultimate factory setting for human life.
It is. But the moment you attach a prefix to that root, the entire clinical picture changes. And this isn't just, an exercise in memorizing medical flashcards.
Right.
When a patient walks through the emergency room doors, the specific pattern of their breathing problem, it dictates an entirely different diagnostic pathway.
Because it tells you where to look.
Exactly. These prefixes represent the difference between a doctor ordering a stat echocardiogram to check the heart, or searching for a pulmonary embolism, or even, evaluating the patient for a panic disorder.
So we're going to decode this NEA family for you today,
Sure.
specifically dyspnea, apnea, and orthopnea, using the sources we've gathered. And okay, let's unpack this by starting with the most common, yet surprisingly the most complex member of the family, which is dyspnea.
Yeah, dyspnea.
The prefix dys means bad, difficult, or painful. So we're talking about the subjective sensation of labored breathing. It's that terrifying feeling of being air hungry.
Air hunger, right. And ancient Greek physicians like Hippocrates and Galen, they were actually documenting these precise breathing complaints thousands of years ago.
Wow, really?
Yeah, the clinical observation is ancient. But what is truly staggering is that for the vast majority of the 20th century, modern medicine fundamentally misunderstood how to evaluate it.
How so?
Well, the medical establishment treated breathing almost exclusively as an input-output equation. It was viewed as a purely mechanical objective problem.
So they just looked at the numbers?
Exactly. Clinicians would look at a pulse oximeter to check the blood oxygen percentage, or they would simply, count the respiratory rate. And if those numbers were within a normal range,
The doctor was just done.
yeah, the respiratory assessment was essentially over.
I have to pause on that because that sounds like, well, institutional gaslighting.
It kind of was.
Right. Like, wait, so for decades, if I went into an ER in 1990 complaining that I felt like I was suffocating and the pulse oximeter read 99%, the doctor would just assume I was fine.
Basically, yes.
That's like telling someone they aren't actually hungry because their blood sugar chart looks perfectly normal. Like, sorry, your glucose is fine. You literally cannot be starving.
That's a great analogy. The data simply did not match the lived reality of the patients. And clinicians were constantly confronted with this paradox.
I mean, they had to be right.
Yeah, they had patients whose oxygen saturation was flawless, whose respiratory mechanics looked perfect on paper, yet these individuals were reporting severe, totally disabling breathlessness.
Right.
The purely objective model was just completely failing to capture the disease. And so this friction, it finally led to a massive paradigm shift in 1999.
Which is pretty late, all things considered.
Very late. But in 1999, the American Thoracic Society, the ATS, they issued a consensus statement that formally redefined dyspnea.
And what did they change?
They declared it to be a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity.
So they finally admitted it is a feeling. It's a sensation generated by the brain, not just a metric spit out by the lungs.
Exactly. The ATS explicitly stated that this sensation arises from a highly complex interaction of physiological, psychological, social, and environmental factors. And by 2012, they actually updated this model to break dyspnea down into 3 distinct measurable dimensions.
Okay, what are they?
First, the sensory perceptual experience. So that's the literal physical sensation, like chest tightness or the feeling of suffocation.
Okay, the physical feeling.
Right. Second is the affective distress, which measures the emotional panic or anxiety caused by that sensation.
Oh, that makes sense, because not being able to breathe is terrifying.
Exactly. And third is the functional impact, or, how the breathlessness limits daily life.
I mean, that entirely rewrites the power dynamic in the exam room. Dyspnea moved from being dictated by a machine's glowing numbers to being defined by the patient's testimony.
It really does. It puts breathlessness on the exact same diagnostic level as pain.
So how do they measure it now?
Well, doctors use tools like the Board Scale or the Modified Medical Research Council Dyspnea Scale, the MMRC, and they literally just ask, on a scale of 0 to 10, how breathless do you feel?
That's fascinating.
Mm.
And it completely changes how you look at the symptoms.
It does, and this redefinition also dismantled a dangerous misconception because a lot of people assume that feeling short of breath automatically means their body is starved of oxygen.
Yeah, that's what I would assume.
But you can have 100% normal oxygen saturation and still experience severe dyspnea.
Like when?
Well, during a severe panic attack, for example, the body is fully oxygenated, but the brain's alarm centers are misfiring, screaming that the airway is compromised.
Right.
Or consider a patient with severe anemia. Their pulse oximeter might read a normal percentage, but because they lack sufficient red blood cells, their blood has a severely reduced capacity to actually carry that oxygen to the tissues.
Oh, so that triggers the intense breathlessness,
Yeah.
even though the oxygen percentage looks fine on the finger monitor.
Exactly.
And I imagine the reverse happens too, right? You can have a patient with adapted chronic lung disease, like COPD, whose oxygen levels are hovering dangerously low, maybe in the 80s.
Yes, exactly.
But because their body has adapted to that hypoxic state over years, their internal alarms just don't ring. They might report zero subjective breathlessness.
That's completely correct. The feeling of dyspnea and the mechanical measurement of blood oxygen are related, but they operate on completely different tracks.
So if dyspnea is this highly subjective internal alarm system, it can be really tricky for a doctor to pinpoint the root cause just by listening to the patient's description.
It can be, which is why clinicians look for objective physical triggers. They introduce new variables.
And the biggest variable, reading through these sources, is gravity, which takes us to orthopnea.
Yes, orthopnea.
The prefix ortho means straight or upright. So orthopnea is dyspnea that specifically occurs or worsens when a person lies flat, and then it improves when they sit or stand up.
Right, and Sir William Osler, who's often considered the father of modern medicine, he formalized this specific terminology in his landmark 1892 textbook, The Principles and Practice of Medicine.
1892, wow.
Yeah, Osler popularized orthopnea as a crucial diagnostic wedge to differentiate breathlessness caused by the heart from breathlessness caused by the lungs.
Interesting.
And that specific distinction remains a core exercise in cardiology and pulmonology today.
Let's get into the mechanics of this, because the underlying fluid dynamics are honestly fascinating. Why does simply lying flat in a bed cause someone to feel like they're suffocating?
So the classic textbook cause of orthopnea is left-sided heart failure. The left ventricle of the heart is responsible for pumping oxygenated blood out to the rest of the body.
Right.
When it fails, it loses its forward pumping efficiency.
So think of the left ventricle like a sump pump in a basement. If the pump is old and failing, it might just barely keep up with a slow trickle of water.
That's a perfect way to visualize it.
They manage to keep the basement dry, as long as the water volume stays low.
Right, and taking that sump pump analogy a step further, consider what gravity is doing when that patient is standing up all day. Gravity is pulling a significant portion of their blood volume down, pooling it in the veins of their legs.
So the failing heart, the sump pump, isn't dealing with all that fluid at once.
Exactly. But the moment the patient lies flat in bed at night, gravity is neutralized. All of that pooled blood from the lower extremities suddenly rushes back up toward the chest.
So the basement suddenly gets hit with a flash flood.
Yes. The failing left ventricle is instantly overwhelmed by this massive influx of volume. It cannot pump the blood forward fast enough, so the pressure backs up into the pulmonary veins, which are the vessels leading from the lungs to the heart.
Okay, I see where this is going.
That intense pressure literally forces fluid out of the blood vessels and into the tiny air sacs of the lungs. This is pulmonary edema.
Oh, wow.
The patient is quite literally beginning to drown in their own internal fluids, entirely provoked by the act of lying flat.
Which perfectly explains this incredible historical shorthand cardiologists use called the pillow scale.
Yes, the pillow scale.
Because if you're drowning when you lie flat, your instinct is to sit up, right?
Yeah.
So gravity can pull that fluid back down away from your lungs. So doctors simply ask patients how many pillows they use to sleep.
It's remarkably practical.
It is. If a patient says, I have to prop myself up on 3 pillows to get any rest, the doctor charts 3-pillow orthopnea. It's incredibly visceral, but it also sounds like a terrible metric.
How do you mean?
Well, my firm memory foam pillow creates a completely different angle of elevation than some flat feather pillow from a cheap hotel.
Oh, yeah, absolutely. It is an entirely unstandardized subjective unit of measurement. I mean, a pillow does not equal a specific degree of incline,
Right.
yet it perfectly captures the patient's functional limitation.
Huh.
The pillow scale actually survives in modern cardiology notes and even in cutting-edge heart failure research.
Really?
Still today. Yeah, simply because it translates complex pulmonary pressures into a very relatable human behavior.
We should clarify, though, that orthopnea isn't always a failing sump pump. Right.
Good point. Differential diagnosis is critical here. While orthopnea is the classic red flag for heart failure, any condition that severely limits the diaphragm's ability to move when lying flat can cause it.
Like what else?
Well, we see it in severe COPD, in bilateral diaphragmatic paralysis, or in cases of massive abdominal pressure. Like if a patient has severe obesity or ascites, which is a massive buildup of fluid in the abdomen from liver disease.
Oh, so the fluid just pushes up.
Exactly. Lying flat causes that mass to push upward, physically crushing the lungs and restricting their expansion.
Okay, so orthopnea is finding relief by sitting up, actively fighting gravity.
Hmm.
But eventually, the patient has to sleep. They lose conscious control over their posture and their breathing effort.
Right.
And that brings us to the scenario where the breathing doesn't just struggle, it stops. Apnea. The prefix of means without or not.
Apnea is the temporary or complete absence of breathing. And understanding apnea requires dismantling a fundamental assumption most people have about human biology.
I'll admit, I definitely had this wrong before reading these sources.
Most people do.
Because if I dive underwater and hold my breath, after about 30 seconds, my chest starts to burn. I feel a desperate, panicky urge to inhale. I have always assumed that feeling is my brain realizing my oxygen tank is running on empty. It feels like oxygen starvation.
Yeah, and the biology actually points in the exact opposite direction. The urge to breathe is not driven by falling oxygen levels.
Which is wild.
It really is. It is driven almost entirely by rising carbon dioxide.
Okay, explain that.
So, the human respiratory drive is a chemical feedback loop managed by tiny sensors called chemoreceptors. These are located primarily in the brainstem and the carotid arteries. And these sensors are not particularly sensitive to oxygen. Instead, they constantly monitor the pH, the acidity, of the blood.
Because when we produce carbon dioxide as waste and hold it in, it changes the blood chemistry.
Right. As carbon dioxide builds up in the bloodstream, it dissolves and forms carbonic acid, making the blood more acidic.
Okay.
Those brainstem chemoreceptors detect the dropping pH and fire off a panic signal to the diaphragm saying, too much acid. Vent the Ca2 immediately.
Wow.
This is why freedivers can hold their breath for 5 or 6 minutes. It's not because they have massive lungs, but because they actually train their brains to tolerate extreme carbon dioxide buildup without triggering that panic response.
Which perfectly explains the terrifying mechanics of sleep apnea. Because if a person's airway collapses in their sleep, you would assume their brain would instantly wake them up the second their oxygen drops.
You'd think so.
But because the alarm is tied to CO2, and because the sleeping brain inherently blunts that chemoreceptor response, the sleeper doesn't feel the suffocation. They can stop breathing for 30, 45, even 60 seconds. They sleep right through the oxygen desaturation.
Yep, it's completely silent to them.
It's usually the bed partner who lies awake, listening to the dead silence, just waiting for the brain to finally register the toxic CO2 levels and trigger a violent, gasping snort to reopen the airway. And then the person suffering the apnea usually wakes up feeling exhausted, but with zero memory of actually stopping breathing.
That silent mechanism is exactly why obstructive sleep apnea is a massive hidden epidemic, and the data on this is really sobering.
Let's talk about the Wisconsin study.
Yeah, the landmark Wisconsin sleep cohort study. It was originally published in 1993, and they brought middle-aged adults into a lab for full polysomnography, measuring brain waves, oxygen, and airflow.
And what did they find?
They discovered that the vast majority of people experiencing significant apnea events had never been diagnosed. And a follow-up analysis of that same cohort in 2013, adjusting for rising obesity rates, estimated that 26% of adults aged 30 to 70 in the U.S. have at least mild obstructive sleep apnea.
Over a quarter of the middle-aged population. Yet, and here's where it gets really interesting, the clinical presentation was actually recognized through literature long before anyone ever hooked a patient up to an EEG machine.
Oh, this is a great piece of history.
Back in 1956, an American physician named C. Sidney Burwell noticed a specific pattern in extremely overweight patients who were perpetually sleepy. He didn't have sleep lab technology, obviously, so he named the condition Pickwickian syndrome.
After the Dickens character.
Exactly. He named it after Joe, the fat boy servant from Charles Dickens's 1836 novel The Pickwick Papers, because the character was constantly falling asleep while standing up.
Burwell literally leveraged Charles Dickens's brilliant clinical observation from a century prior to categorize what we now call obesity hypoventilation syndrome.
It's amazing.
It just proves that the behavioral signs of severe apnea were always visible, even when the internal mechanism was completely invisible to science.
But the idea of a loved one just stopping breathing in their sleep is inherently terrifying. And historically, that very plausible fear has driven some intense medical debates and even consumer panic, where the anxiety got way out ahead of the actual science.
Right.
We see this perfectly illustrated in the sources with the sudden infant death syndrome, or SIDs, controversy of the 1970s and 80s.
Yes. SIDs is a devastating tragedy. And in the search for answers, a highly plausible hypothesis emerged. Doctors thought perhaps undetected apnea episodes, just brief pauses in an infant's breathing, were the precursor to SIDs.
And the logic seemed sound right. If apnea causes breathing to stop and infants are tragically dying in their sleep, those breathing pauses must be the culprit.
Exactly.
But plausible panic is a powerful market force. This theory spawned an entire commercial industry of home apnea monitors. Parents were buying these devices, strapping them to their baby's chest, terrified that if the alarm didn't sound when the baby paused their breathing, the child would die.
It was a huge industry. And these devices were mass-marketed to desperate, fearful parents without rigorous scientific evidence proving they actually altered SI's outcomes.
So it changed.
The turning point arrived with the CI study, the Collaborative Home Infant Monitoring Evaluation, which was published in JAMA in 2001. After monitoring thousands of infants, researchers found no evidence that these home monitors reduced the incidence of SIDs.
Wow, none.
The plausible theory simply didn't hold up to large-scale data.
But SI's rates did plummet dramatically in the 1990s. If the chest monitors weren't saving these babies, what was the actual mechanical fix?
The massive drop in SIs was almost entirely driven by the Back to Sleep campaign.
Oh, just changing their position.
Yes. Public health officials educated parents to place infants on their backs to sleep, rather than on their stomachs. This simple, low-tech positional change kept airways open and prevented infants from rebreathing trapped CO2-heavy exhaled air that pooled in their mattresses.
So the mechanical fix was posture, not a digital alarm.
Precisely. Furthermore, the medical community realized that periodic breathing in newborns is actually completely normal.
Wait, it's normal for them to stop breathing?
Yeah, healthy infants will naturally pause their breathing for 5 to 10 seconds, followed by a burst of faster breaths. Pathological infant apnea actually requires pauses of 20 seconds or longer, or pauses accompanied by severe heart rate drops.
This tension between over-monitoring and actual pathology brings us directly into the modern debate surrounding adult sleep apnea. Specifically, how sleep specialists measure severity using the AHI, the Apnea-Hypopnea Index.
Right, the AHI.
Because the AHI calculates the average number of breathing pauses per hour of sleep. The standards thresholds define 5 to 15 events as mild, 15 to 30 as moderate, and 30 or more as severe.
That's the current standard.
But looking at the mechanics we just discussed, this index seems wildly flawed. I mean, if I have 15 apnea events an hour, but they only last 11 seconds each, my AHI is 15. But if another patient has 15 events an hour, but theirs last 45 seconds each and their oxygen plummets, their AHI is also exactly 15. The metric treats a minor hiccup and a near suffocation event as identical.
This raises an important question, and honestly, that flaw is the center of a massive debate in sleep medicine today.
I would imagine so.
Yeah, the AHI is purely a frequency counter. Critics argue that relying solely on the AHI leads to overdiagnosing patients who have frequent but physiologically harmless pauses. And on the flip side, it severely underdiagnoses patients who have fewer events but suffer massive physiological tolls from extreme oxygen desaturation and severe sleep fragmentation.
Which really makes me question the data coming from the smartwatch on my wrist. I mean, millions of people wake up and check their sleep scores and blood oxygen charts.
Oh, absolutely.
Are these consumer gadgets underestimating our AHI because they can't actually read our brain waves to know exactly when we fall asleep? Or are they fueling anxiety by overdiagnosing every little 10-second twitch?
The reality is it's a messy combination of both. Home sleep tests and wearables are incredible tools for broad public health screening, and they're vastly cheaper than an overnight stay in a clinical lab.
Sure.
However, because most lack EEG data, the brainwave monitoring required to precisely stage sleep versus simply lying motionless awake, they often miscalculate total sleep time, and that skews the AHI denominator.
Right.
We are navigating a transition period right now where the sheer volume of data generated by consumer gadgets is radically outpacing the clinical consensus on how to interpret it.
Well, we've mapped out dyspnea, orthopnea, and apnea, but I want to spend our last few minutes looking at the extended NEA family tree because the human body has some incredibly bizarre plumbing shortcuts.
It really does.
Let's establish the baseline first. Normal, unlabored breathing is eupnea. If your respiratory rate speeds up abnormally, that's tachypnea. If it slows down abnormally, that's bradypnea. But the weirdest relative in this family has to be platypnea.
Oh, platypnea is fascinating. It's the exact mirror image of orthopnea.
So.
With platypnea, a patient's breathlessness actually worsens when they sit or stand upright, and it miraculously improves when they lie flat.
That sounds like it defies gravity. If fluid pools in the lungs when you lie down, how could standing up make breathing harder?
It happens because of a completely different mechanical failure. It usually involves abnormal vascular shortcuts called shunts.
Okay, shortcuts in the blood vessels.
Right. Platypnea is almost always paired with orthodeoxia, which is a measurable drop in blood oxygen when upright. We see this in specific structural defects, like a hole between the right and left chambers of the heart, or in hepatopulmonary syndrome caused by severe liver disease.
So what happens when they stand?
When the patient stands up, gravity pulls their blood flow through this abnormal shortcut, entirely bypassing the oxygenating network of the lungs. The unoxygenated blood cycles right back into the body.
Wow.
But when they lie flat, the gravitational pressure shifts, the shortcut closes or minimizes, blood routes back through the lungs properly, and the breathlessness resolves.
It proves that posture-dependent breathing isn't solely a heart failure issue. It's a profound clue about the internal architecture of the blood vessels.
Exactly.
We also see history embedded in these terms through eponyms, like Cheyne-Stokes respiration.
Right, named after John Cheyne, who documented it in 1818, and William Stokes, who expanded on it in 1854. Cheyne-Stokes is a deeply ominous cycling breathing pattern.
What does it look like?
The patient's breaths gradually become deeper and faster, then slowly shrink down until breathing stops entirely for a period of apnea, and then the cycle repeats. It was historically observed in patients dying of severe heart failure or catastrophic brain injury.
When you pull all of these sources together, you realize these aren't just trivia terms for a biology exam. They dictate immediate high-stakes triage.
They absolutely do.
If a patient arrives in respiratory distress, the exact flavor of the symptom points directly to the underlying disease. Does the breathlessness wake you up from a dead sleep? That suggests paroxysmal nocturnal dyspnea.
That's right.
Does it only happen when you try to sleep flat in bed? That's orthopnea. Is it completely silent, pausing while you remain asleep? That's apnea.
And this framework has never felt more urgent than in the wake of the COVID-19 pandemic, which brought a terrifying new variation into public awareness: silent hypoxia.
Oh, right. We suddenly had ERs filled with patients whose oxygen levels were dropping to leakily low levels, but who lacked the subjective sensation of dyspnea.
Yes.
Their internal CO2 alarms just weren't triggering. That catastrophic mismatch between the mechanical reality of their failing lungs and their subjective feeling of being fine meant patients sought help dangerously late. It's why pulse oximeters became household items overnight.
It was a stark reminder of how fragile the human body becomes when the subjective sensation of breathlessness gets uncoupled from the actual mechanics of gas exchange.
Which leaves us with a fascinating tension to consider. In 1999, the American Thoracic Society made a massive humanizing leap. They decided to officially trust the patient.
Which was huge.
They declared that a patient's subjective experience of breathlessness, their dyspnea, mattered just as much, if not more, than the objective data spit out by a pulse oximeter. Medicine chose to validate the human feeling over the machine.
But consider the trajectory of consumer health tech today. We wear devices that constantly calculate our AHI, log our nocturnal oxygen dips, and analyze our sleep fragmentation down to the minute.
Right.
Are we in danger of swinging the pendulum completely in the opposite direction?
Exactly. Will the future of medicine force us to let a consumer algorithm define our NEA experiences? Are we going to stop trusting how rested or fatigued we actually feel when we wake up, and instead let a smartwatch dictate our reality?
It's a very real possibility.
It's like we're becoming completely obsessed with staring at the check engine light on the dashboard, and we've forgotten how to feel the way the car is actually driving on the road. Thank you for exploring these sources with us in this deep dive today. Next time you catch your breath, take a second to appreciate exactly how much biological machinery is humming perfectly in the background to make it happen.